All right, so let's talk about respiratory emergencies. So this is going to be one of the most common between this and cardiac that we're going to respond to, especially more now than ever with COVID and everybody else being scared of COVID and COVID symptoms and things like that. We're going to be running into a lot of respiratory emergencies. This week alone, I think I've gone to about 4 or 5 just on the ambulance alone this week that involve some kind of respiratory emergency, whether it be pneumonia, CHF, which is cardiovascular, but then also turns into respiratory due to the pulmonary edema. So this is something we're going to see a lot of, so we're going to kind of hit this pretty heavy between cardiovascular and respiratory. So obviously we have to meet the National EMS Education Standard competencies. So medicine applies fundamental knowledge to provide basic emergency care and transportation based on assessment findings for an acutely ill patient. With that, though, we have to know respiratory. So understanding anatomy, signs and symptoms, and management of respiratory emergencies, including those that affect the upper and lower airway. So we do have medications that we can administer to assist with this, being a albuterol inhaler, which is an MDI or meter dose inhaler, and understand how that works getting into the system. But we also have the ability of utilizing CPAP. CPAP is something new to the EMT level, especially for New Hampshire. Massachusetts now has it, and I have to look at the new protocols for Maine. I have been a little lazy on this and haven't done the protocol update yet, but I will be getting that done this week to kind of refresh so I can get you guys up to speed as well for that. So respiratory emergencies, upper and lower airway. We also have to learn where the anatomy, physiology, and pathophysiology assessment and management of epiglottitis. And we're going to see a lot of this in pediatrics. Spontaneous pneumothorax, which is nothing that we're going to be able to do for that in the field at the EMT level, but be able to recognize the signs and symptoms. Pulmonary edema, we have a patient with left-sided heart failure, obviously asthmatics, and then chronic obstructive pulmonary disease or COPD. And we see a lot of that in the elderly community, especially during this time of year where we start seeing the warm and cold and patients having some difficulty of time breathing. It turns into what they call a COPD exacerbation, which is where the patient exacerbates the condition that they currently have. We're also going to talk about environmental and industrial exposure. We'll go over some toxic gases, pertussis, cystic fibrosis, and pulmonary embolisms. Along with pneumonia and some viral respiratory infections. So patients often complain of dyspnea. Dyspnea is shortness of breath. And this is going to be very important when we get into our assessments. One second. All right. Let's have to reply back to a chat. So obviously with patients complain of shortness of breath, dyspnea. So when we're doing our assessment, we look at the amount of words they can speak in one sentence. And we use that as a dyspnea type level to see where they kind of sit. So if they're speaking in full sentences, we know the shortness of breath is not very difficult. But if they're doing 1 word or 2 word or 3 word before taking the next breath, then we know they're starting to struggle a little bit more. This becomes what we call word dyspnea and becomes more of a difficulty of breathing. This can be caused by many different conditions. Again, asthmatics to COPD, bronchitis, emphysema, and things like that. So the cause can be difficult to determine, but really it's not really hard to figure out what's really going on if you ask the appropriate questions and get a good medical history. At that point, and then do a good assessment, we can kind of find out a rough idea of where this is going to be going down the road. All right, so the upper airway consists of structures above the vocal cords. This will be your nose and mouth, which would be your nasal cavity and your oral cavity, your jaw, your pharynx, and your larynx going down into your trachea on the picture here. So if you look at the picture, we have the upper airway, which is described as the pharynx up top. So you can see the nasopharynx. And you guys can see my mouse on the screen, correct?
Yes, I can.
Perfect. Okay, so it is moving for you. All right. And disappeared. So the nasopharynx starts right in here, in this area. This goes back into the pharynx, which is located back here, into the oropharynx, which is located here through the oral cavity, so through the mouth. As it comes down, it goes through the epiglottis. The epiglottis is the flap of skin that blocks, whether it be when you're breathing, it opens up your trachea to be able to breathe, and it closes. Pause it for a minute there. And also closes as well when you're trying to eat food and digestion as well with that. So sometimes with especially pediatrics during this time of year getting into the winter months, the epiglottis can become infected and start becoming inflamed. Then we have what they call epiglottitis. This would be an upper airway issue. It comes down through the larynx. In the larynx, that's where your vocal cords are as well. And it goes down into the lower airway, which starts at the trachea. So anything below the trachea, so your asthmatics and things like that, are all lower airway issues where you can have mucus buildup. We'll get into all this here in a little bit. With that, you have your trachea. The trachea comes down into the right and left main bronchi or bronchus. This point where it splits from side to side, that's called the carina. So the carina is a splitting point where it goes from right to left. As it comes down through, it goes into the bronchioles, which come out to here. And at the end of the bronchioles, go into the alveoli, and those are your air-filled sacs. The air-filled sacs, as you can see here where the pulmonary capillaries are, that's where that gas exchange that I was talking about is happening. And this is where it's going to be important for your COPD patients and things like that once we get more in depth in the respiratory system in this presentation. But the alveoli is going to be important to get this medication in and push it in. That's why we use CPAP to kind of help with that, providing positive and expiratory pressure. So we mentioned that a lot in previous classes, where if you purse your lips and you breathe out, it keeps your lungs open for a longer period of time. That's what CPAP is doing, is applying pressure against your outgoing breath. That way there it allows your lungs to stay open a little bit longer, allows the alveoli to have proper gas exchange, which then in turn can help push fluids out of your lungs and or oxygenate for those bad COPD or asthmatic patients. So the principal function of the lungs obviously is respiration. We need to have that exchange of oxygen and carbon dioxide. So remember, air comes in and goes round and round inside. Okay, oxygen comes in, it gets transported by hemoglobin. Hemoglobin then transports it through the entire body, and then it comes back through the veins, deoxygenated, it comes back into the lungs, and that's where the exchange is now happening. So carbon dioxide is pushed out as you're exhaling. As you're inhaling, more oxygen is coming back in. So air travels through the trachea into the lungs, through the bronchi, which are your larger airways, into the bronchioles, which are your smaller airways, which I described in the previous slide, and then into the alveoli, and that's where your pulmonary capillary beds are located. Right? That's why it's very important to make sure that we do not lose these alveoli to whether it be fluids or mucus buildup and things like that that's causing us to be able to not breathe. So the respiration process is inspiration and expiration, not inhalation, exhalation, but inspiration and expiration. So we're inspiring oxygen coming through, and inspiration is when it starts going through the bloodstream. And as we're exhaling, would be the expiration, expiring your carbon dioxide out of the system. Oxygen is also provided to the blood through this and being transported by hemoglobin in cells. All right, but then carbon dioxide being removed, and then this takes place rapidly at the level of the alveoli. So again, this is where things are happening, and we got to make sure that the alveoli are staying open. Along with the alveoli, there are certain things that keep the elasticity of the alveoli to be able to expand and contract. That's something called surfactant. So surfactant helps keep it lubricated so that way there it expands and closes. But once they lose that surfactant level and they become very dry, they can collapse, and they stay collapsed without that electricity that's there. And when they collapse, that's called atelectasis. So atelectasis is when you have alveolar collapse, and in turn, you're going to have poor oxygenation. These are patients that are eventually going to have respiratory failure. So looking at the physiology of respiration, as you can see, my mouse again, breath comes in. As it's coming in here, oxygen is then pushed into the capillary bed, which then goes into the arteries, which then transports through the body, through the heart, around the body, as it's going through the rest of the capillary beds, like in the top of the skin layers and whatnot. That's where that exchange is also happening as well, taking that deoxygenated blood back through the venules into the veins, going back to the heart, back to the lungs, taking that deoxygenation or carbon dioxide gas, and we're pushing it back out. So if you look at the picture here with the tissue cells toward the right-hand side, as you can see, we have red blood cells. Red blood cells also have hemoglobin, and the oxygen attaches to hemoglobin for transport. This is done with gases moving from one to the next, not a fluid. So this would be diffusion from the area of greater concentration to an area of lesser concentration, moving that gas through. By doing that, oxygen and nutrients go in, carbon dioxide and waste come out. We take a deep breath, we take a breath out, and that releases our carbon dioxide. That's going to be important to know when we start talking about end-tidal CO2 or end-tidal carbon dioxide, looking at readings, which is new to the EMT level, as we are utilizing, especially in New Hampshire, King Airways. So we'll get more into that. We do practical sessions as well on how to apply mainstream end-tidal and be able to actually see these waveforms and to be able to see that the patient's actually off-gassing the appropriate way. So in the alveoli, oxygen passes into the capillaries. Carbon dioxide returns to the lungs, breath out, it gets removed. The brainstem senses blood carbon dioxide levels. So when it breathes high, it'll increase your breathing rate to start off-gassing more. If it's low, it slows down your rate. This regulates your breathing rate and depth. So your brainstem does all this. It actually functions and looks at how much carbon dioxide levels are in your system. And then in turn, through the nervous system, it starts helping you breathe and changes your rates. So if you have a patient who's involved in traumatic injury and they have issues to the brainstem, can you see how this could become a problem, right? So we got to make sure we're paying attention to our assessments when we get into this. So again, we'll talk about more of this after the physiology of all this stuff. So the pathophysiology behind it is oxygen exchange can be hindered by a couple of things. Conditions in the anatomy of the airway. So again, anaphylaxis, right? So if you have a patient's anaphylactic shock or anaphylactic reaction, they could have what they call angioedema or a swollen tongue to the point where their airway is starting to swell up, right? So we have a bunch of histamine being released into the body. We're causing intense swelling everywhere. And that's why epinephrine is such an important medication, because that causes that vasculature to constrict, allowing to open up the airway even more to help them breathe. There are other disease processes out there. We talked about cystic fibrosis. We're going to talk about cystic fibrosis. Also, we're going to look at COPD, asthma, epiglottitis, croup, things like that that can actually hinder oxygen exchange due to increased swelling in the airway. Traumatic conditions that can also hinder this would be, let's say, any kind of injury to the chest or the trachea. Chest injuries can cause a pneumothorax or a tension pneumothorax, where we have injuries to the chest causing a lung to collapse. There's nothing at the EMT level that can be done with that, but early recognition can start the paramedics to be able to do a chest decompression. We also have other issues, abnormalities in the pulmonary vessels as well. Other things that can also hinder oxygen exchange is high levels of carbon monoxide and more of your toxins with that, because the infinity levels of carbon monoxide are much greater, which will then replace the oxygen on the hemoglobin. So if you place a patient on a pulse oximeter, you're going to see a reading of 100%, but yet they still can't breathe. What's really going on? Really, it's picking up. Pulse oximeters only pick up what's on that hemoglobin and on the cells being transported. It doesn't tell you what's on it. It just says, hey, look, there's something attached to it. So it looks like it's pretty good. So that can give you false readings. Also, patients that are very anemic can also give you higher readings of SpO2, saying there's good oxygen when really they need oxygen. So treatments for those would be nasal non-rebreather at 15 liters a minute, high flow. Recognize the signs and symptoms of inadequate breathing and know what to do about it. How do you fix it? Whether that be using a nasal cannula, a non-rebreather, or a BVM. Also, some patients have chronic carbon dioxide retention. So use caution when administering oxygen. Those patients that have carbon dioxide retention, or what they call CO2 retainers, are going to be your COPD patients, where a pulse oximetry reading may read 90%, which in our world, in EMS, anything below 94 gets oxygen. They probably don't need that because they live at that state all the time. Now, if you give it to them short term, not a big deal, not a problem at all. If they're going to be on it long term, multiple hours, days, this can actually cause a big effect because they are retaining that carbon dioxide, which is what they live at a normal level. Other things you may see because of the carbon dioxide retention and the breathing difficulty they have is something called increased AP diameter. And increased AP diameter is going to be that barrel chest. So we'll talk about barrel chest in your COPD patients later on in the presentation. So some causes of dyspnea, obviously patients that have dyspnea or hypoxia, so lack of oxygen, shortness of breath, will have pulmonary edema. Okay, so again, take a good listen to lung sounds. Pulmonary edema you'll see on both sides of the lungs when you listen, when you auscultate the lungs. Remember how I showed you guys how to do it in your practical sessions? We need to go side to side, almost like in a Z-type pattern, to compare both sides of the lungs to see where that fluid buildup may be. This is caused by a patient who has left-sided heart failure. Hay fever, a pleural effusion as well, obstruction of any of the airway, so that could be a foreign body airway obstruction to just obstruction through swelling based upon a reaction and histamine release. Hyperventilation syndrome. This can cause patients to black out. This is what I teach in my water rescue classes that I do, is hyperventilation syndrome can also be what they call shallow water blackout. And that's how we see a lot of drownings, because you hyperventilate to the point so much that you're retaining all that carbon dioxide to the point where you actually pass out. Environmental or industrial exposures, any kind of toxic environment, carbon monoxide. Obviously, drug overdose. Because remember, there's also medications out there like opiates that depress the respiratory system to the point where patients stop breathing and become very cyanotic. So that's also something we need to pick up on. And remember from the previous toxicology lecture that we did, we got to look at toxidromes. So those are your series of signs and symptoms that would indicate that there's a problem and how do we fix it. One of the biggest ones that we see nowadays is going to be your opiate overdose. We're seeing a lot of that. We just had a recent one the other day on fentanyl overdose. So again, decreased respirations, altered mental status or unresponsive, pinpoint pupils, the classic triad of what we're looking at for these patients to make the assessment. And then the treatment for that is going to be Narcan. Dyspneic patients may have gas change obstructed. So you're going to see dyspnea or damaged alveoli in patients that have COPD. Obstructed airway passages, again, asthmatics, which is a buildup of mucus in the lungs, in the bronchioles. And what we need to do for these patients are actually giving them bronchodilators. So some bronchodilators that exist out there would be like duonebs. So duonebs have albuterol, which is a sympathomimetic medication, which mimics the sympathetic nervous system. By doing so, it increases heart rate, but it also functions as a bronchodilator. So this is what they would call a alpha 2 or alpha 1 beta 2 medication for this, because it figure alpha 1 one heart, beta 2, or sorry, I read that backwards, disregard that, beta 1 beta 2, not alpha. Alpha is more for vasculature, so it'd be a beta 1 beta 2, which means it increases heart rate, but then beta 2 lungs, also has an effect of the lungs. And albuterol is causing bronchodilation, but then it also has something called ipratropium bromide in a duoneb that is helping with a steroid to help keep those lungs open a little bit longer and kind of help with that respiratory cycle without getting too in depth on that. So albuterol, duoneb, and if we're giving someone albuterol for the dyspneic patient, like an MDI inhaler, that's going to have the beta 1, beta 2 effects, because you're going to see potential increased heart rate. So you'll see some tachycardia with it, but you also have the bronchodilation beta 2 effect causing those to stay open. That's why they get the sympathomimetic as part of the autonomic nervous system. I'm sure I lost a lot of you on that. Again, review the slide and the presentation again later, because all this stuff actually plays a part in what we're doing. So anytime you treat a patient, remember there's a cause and effect to what we do. So if we're doing something, there's going to be an effect to it. So if we're giving somebody an MDI inhaler at the EMT level, or giving someone nitro at the EMT level, or oxygen, oral glucose, there's going to be an effect to it. Hopefully we're going to see that positive effect. But having the pathophysiology behind it, understanding how it works in the body, will make your assessment and your treatment that much better. So obviously there are other things with obstructive air passages, obstructive blood flow to the lungs. So the blood flow part would be something like a pulmonary embolus, because now we have a clot built up in the pulmonary arteries that's causing the patient not to be able to breathe. Or excessive fluid in pleural spaces, that would be your pleural effusion, where you have fluid build up in the lungs as well, but not inside the lungs, but in the pleural space of the lungs, causing the patient to have difficulty breathing. This can cause the dyspnea. Did I lose anybody in any of that? There's quite a bit. Everybody good?
I got it.
Okay. Again, if you have any questions,
I'm gonna have to review it.
yeah, no, definitely. And again, read the book as well. That's in the ebook, and look at that. And they'll go more in depth as well. But again, you have to have an understanding of what you're doing, and not just following a protocol because your protocol says so. But if you know what you're doing behind it, that helps with your treatment plan. So I want to take that EMT level you guys are getting and take it one notch above that to make you better providers for the field. That's only going to make your patient care better. So some signs and symptoms of inadequate breathing. The patient reports they have difficulty breathing or shortness of breath. If they say, even if their pulse oximetry reading reads 100% and they say they're short of breath, give them oxygen. There's nothing wrong with that. A patient has an altered mental status associated with shallow or slow breathing. Again, give them oxygen, but you may have to assist their breathing using a bag valve mask. The adult patient appears anxious or restless, and the pediatric patient appears sleepy or listless, so not really moving, very lethargic. Inadequate breathing can cause this. The leading cause of cardiac arrest in pediatrics is respiratory distress and respiratory arrest first. Pediatrics should not be coding. They shouldn't be. Their hearts should be perfectly fine. Unless they have a predisposed condition, usually it's a respiratory condition causing the cardiac arrest. The respiratory rate is too fast or too slow. What are the normal ranges for breathing rates for adult, child, and pediatric? You guys remember those at all? Any thoughts?
12 to 20. Honestly, no.
12 to 20 is adults, so it'd be above 20, right? Or
so the child would be 15 to 30, and the infant is 25 to 50. That's your normal ranges. And you can have tachypnea, too fast breathing, or bradypnea, which would be your slow breathing. So rapid or decreased respirations. Either way, whether it's rapid or decreased, we can assist that with a BVM to control it. The only difference is, remember, they are still breathing. So when you use a BVM and you squeeze the bag, you have to do that on the inhalation to kind of help them control that and trigger the response to help them breathe better. If the breathing pattern is irregular, we'll go over that in a little bit on different irregular breathing patterns, from biots to Cheyne-Stokes breathing and things like that. Adventitious breath sounds are heard, including wheezing, gurgling, snoring, crowing, a stridor, which is a harsh, high-pitched barking sound. So wheezing, gurgling, snoring are mostly lower respiratory. Again, your snoring, which will be kind of like your tongue falling back in your airway. Crowing sounds, or the stridor, which is like the seal bark sound. Those are important upper airway. And one of the biggest ones we're going to see, and we're going to start seeing that, and I can almost guarantee you'll have patients like this in the next 2 months. It's going to be croup, because we're in that season where we have the warmer weather during the day and the cold weather at night. And we're going to start seeing patients that have croup. And mostly it'll be your pediatrics. And then they'll call 911, you'll show up, they'll be outside, and it'll be perfectly fine. They're like cured, but they're not. They still need to go to the hospital to have an evaluation done. And sometimes they even do a chest x-ray. And they go a little more in depth on that. One of the things they'll see on a chest x-ray is something called steeple sign, which is pretty cool to actually see. Not in a kid, obviously, but it actually looks like a church steeple up in their upper airway, because there's a ton of airway swelling because of that. That's what causes that seal bark sound when they cough. Decreased or noisy breathing are heard on one or both sides of the chest. The patient cannot speak more than a few words between breaths. So ask the patient, how are you doing? If the patient cannot speak at all, he or she most likely has respiratory emergency. We talked about that word, dyspnea. You observe accessory muscle use, retractions, or labored breathing. So accessory muscle use being on the accessory muscles up in the neck, you start seeing that indentation, having a hard time breathing. The next thing you'll see is the patient, we'll get that in a second here actually, the patient has unequal or inadequate chest expansion. So remember when I was showing you guys the assessment, and I put my hands on your chest, both hands, professionally, right? I said, take a deep breath, and I felt for equal rise and fall. If they're unequal, and one goes up and one stays the same, that means there's no air getting to that lung. That potentially could be a pneumothorax. So take a good listen to the lung and see if they have absent lung sounds on one side. The patient is coughing excessively, or the patient is sitting up, leaning forward with his or her palms flat on the bed or on the arms of a chair. This is called the tripod position. Because the patient's back and both arms are working together to support the upper body. So kind of lean forward. And the last one is nasal flaring, which you'll see a lot in pediatrics, and then pursed lips, which you'll see more in the adults. And that's them trying to create PEEP to help their lungs stay open a little bit longer to help them breathe. So it's your body's way of trying to help out, keep those lungs open for a longer period of time. The patient also may complain of chest tightness or air hunger, right? So if you have a patient that's breathing really fast or has a lot of coughing, they can develop chest pain. But it's what they call pleuritic pain. It's not necessarily going to be cardiac pain, but doesn't mean that it's not. So again, you can't really rule that out. Patients that complain of the chest tightness could be the fact that they're hypoxic, and your heart needs oxygen to function, right? Remember I mentioned before that your body needs 3 things to stay alive: blood, oxygen, and sugar. Without oxygen, patient dies, right? So with that being said, when your heart starts getting pissed off because you're not giving it enough oxygen, it will start to create chest pain or chest tightness. Doesn't mean they're having a heart attack. It just means they need some oxygen. So usually a nasal cannula or non-rebreather will help with this. This is very common with cardiopulmonary diseases. And pain can cause rapid, shallow breathing because they're in pain, which then in turn can have them retain carbon dioxide or not receive enough. Retain carbon dioxide or not get enough oxygen. So breathing deeply will then cause pain because the chest wall expands and it hurts too much. These patients can really do well with a medic because they can give they can give like a benzo or some fentanyl to kind of help with this, to help relieve that pain so they can actually breathe a little bit better. Upper or lower airway infection. So infectious disease may affect all parts of the airway. Some form of obstruction causes dyspnea, so mucus and secretions obstructing airflow in the major passageways. So that can also be caused by asthmatics with buildup mucus. It could be bronchitis, which has a lot of mucus buildup. Swelling or soft tissue in the upper airways. Any kind of swelling that could be caused from any anaphylactic reaction or allergic reaction to anything. Impaired exchange of gases in the alveoli. Those are going to be a lot of your COPD patients. Also, things that can impair exchange of gases in the alveoli is going to be your pulmonary edema. Because if you have water in, it's kind of like drowning internally. If you have water buildup, fluid buildup in the lungs, you can't exchange gas because it's fluid. It doesn't work that way. So we need to push that fluid out. And part of that would be utilizing CPAP or what we called back in the day, poor man CPAP using a BVM. So here is croup. So as you can see, the swollen larynx and the swollen trachea. That's for that steeple sign thing that I was telling you about looking at an x-ray. You'll see that down by the swollen trachea. The esophagus behind it. You also have a swollen pharynx. By doing so, you'll have that seal bark cough, that stridor. And let me tell you, if you've never heard it before, when you hear it for the first time, you'll be like, my instructor said seal barking. It sounds like there's a seal in the house. And that's what it is. So this is inflammation and swelling of the pharynx, larynx, and trachea. And responds well to humidified oxygen. Now, not every ambulance out there carries humidified oxygen. So some things that do help with this is giving them a nebulizer in the back of the ambulance by putting some saline in it. And then there it starts humidifying a little bit, or some sterile water. And that can help. The sterile water really is not a medication. You're just aerosolizing, causing humidified oxygen. That's all really you're doing. But that's what they need. A lot of times, though, what will happen is they'll put them in like a shower with a lot of steam, and they'll be able to breathe in that humidity. A lot of times that will help as well, and kind of hopefully respond with that humidity. Or they go outside in the cold, and then it kind of goes away because the cold air will reduce that swelling. Very common in younger kids, especially into the seasons we're coming into now. Epiglottitis. These are one of the things where we just don't, even as medics, we don't get involved with. Because you have a swollen epiglottis. If your epiglottis is swollen, it can actually shut down your entire airway to the point where you can no longer breathe. And this is where paramedics get involved and start doing crikes and start putting, or quick trachs, in through the trachea to help them breathe. So this is a bacterial infection causing inflammation of the epiglottis. And children are often found in a tripod position and the excessive drooling. Not a normal 5-year-old drool or 3-year-old drool. This is excessive drooling you'll see with this. So position comfortably, provide oxygen as needed. Again, if they're young and they're crying, they need to stop crying. So don't agitate them, don't piss them off. Just get them to the hospital. Because the crying can actually agitate the epiglottis, causing more inflammation. And again, once it inflames to the point where they can no longer move, it blocks the airway and they stop breathing. Right? So these are patients you want to get to the hospital as soon as you can. If you don't get blood pressures on these patients, then so be it. But these patients just need to get to the hospital. Respiratory syncytial virus, which is RSV, which is a common cause of illness in young children. We see this not as much as we used to, but it's still there. This causes infection in the lungs and the passageways. So we look for signs of dehydration in kids. Again, if they're very, very young, we look at the fontanelle, and if it's depressed in, we know that they're dehydrated. Other than that, have them stick out their tongue. If their tongue is dry and pitted, they're dehydrated. If you pinch their skin, it doesn't go back down very fast, they're dehydrated. Other signs and symptoms would be, I'm not going to say shock-like, but you'll have lower blood pressures and maybe some tachycardia, which is almost like shock, and then eventually can turn into like a hypovolemic issue. But if they're dehydrated, give them some, they can take oral fluid if they can. Other than that, they need to go to the hospital. They're going to get an IV fluid. What's another way to find out, especially pediatrics, if they're dehydrated or not?
No tears when they're crying.
Okay, that's very bad if that happens. What else?
If their skin's tented.
Okay, yeah, skin tenting if they have any, but a lot of the babies are really fat when they're little.
Asking the parents how many wet diapers.
There you go. That's the big one, is how many wet diapers have they had in the last 6 hours, right? And if they say, oh, they've only had one in the last 12 hours, that's a problem, right? Because kids, they pee a lot, right? So we want to see how many wet diapers they actually have had, right? And they tell you minimal, then we know they're very dehydrated. Treat airway and breathing problems that are there, so blow by oxygen if needed. If they won't tolerate it, the best thing to do for these pediatrics in this case, though, as well, is if mom's holding them, give mom the oxygen, have her put it on. There's nothing wrong with that, because the kid's going to be more apt to work with mom than they are going to be working with someone they don't even know. And humidified oxygen is always helpful, but not a lot of ambulances carry humidified oxygen. I know a lot of services have taken it off because they don't want to spend the money on the humidified system. So that could also become a problem, but not a huge problem. Bronchiolitis is a viral infection illness often caused by RSV. When I was working in the ER, we had quite a few kids that came in with bronchiolitis, and we just discharged them home. Usually affects newborns and toddlers. We saw a lot of that. When the bronchioles become inflamed, they swell and fill with mucus. So you'll have a lot of mucus coming up. It could be a productive cough. It's going to be yellow and greenish color. But again, they might get some antibiotics, and they'll send them home. Not all the time do they admit pediatrics with bronchiolitis. Pneumonia, one of the most common hospital-acquired diseases that are out there. So bacterial pneumonia will come on quickly and result in a high fever. But not all pneumonias have fever. Viral pneumonia presents more gradually and less severe. So if you have a viral pneumonia, that's not really contagious. Your bacterial stuff is where your contagious pneumonia is located. But again, we didn't see a ton of pneumonia in the last year because of COVID and everybody else wearing masks. So that's actually brought that stuff down quite a bit. Prior to masks and pre-COVID, we saw pneumonia a lot, pneumonia and flu. These patients here will be very lethargic. They're probably going to be very dehydrated as well. Check their blood pressures, obviously pulse oximetry, breathing rates, and all your normal vital signs that you would do. And then treat the patient from there. If they need oxygen, give them oxygen. Especially affects people who are chronically ill. So anybody that's had any kind of chronic illness, COPD, can develop pneumonia pretty quickly. Other things that can develop pneumonia as well would be your trauma patients, especially if they have like broken ribs or things like that, because they're not getting that full inhalation and exhalation, so they end up keeping a lot of that stale air inside. And that stale air can cause pneumonia. Another thing that can cause pneumonia is aspiration. That's what they call aspiration pneumonia. And that's if somebody aspirates something. It could be a piece of food or anything like that. If they're eating and they swallow it and it goes down their airway. I had a guy that had really, really bad pneumonia to the point where it collapsed his lung because he inhaled a piece of tinfoil on a candy bar wrapper, got into his lung, collapsed his lung. I did a decompression on him, and I must have pulled out, no joke, about 30, 20 ml flushes of straight pus. And then I attached it to a suction canister, and I pulled out an additional 300 mLs of pus out of his lungs until DART showed up, where they end up placing a chest tube. And this was called for a simple fall. So again, pneumonia can attack you quickly and can cause a lot of problems. Assess temperature and provide airway support and supplemental oxygen with these patients, and check their temps. Again, they can still have pneumonia and not have a fever, though. Pertussis is an airborne bacterial infection that mostly affects children under 6. These are what they call the whooping cough. So patients will be feverish and exhibit a whoop sound after a coughing attack. I have not seen much pertussis in 22 years I've been doing this. But again, something to just be aware of if you see it. These patients will require probably IV therapy for dehydration and then suction the airway as needed. Influenza type A became a pandemic in 2009. Again, because of COVID and the masks. Working in an ER, I think I saw one patient all winter long, last winter, that got diagnosed with flu. Other than that, it was all COVID diagnoses. So symptoms include fever, cough, sore throat, muscle aches, headache, and fatigue. Then may lead to pneumonia or dehydration. Influenza type A, these patients become pretty sick. But they're treated with antibiotics, oxygen, sent home, and bed rest. Tuberculosis, or with the TB, this is something in EMS that we get tested for on a yearly basis. What they do is they implant a PPD test under the skin. 48 hours later, they need to read the test. If it's blotchy all around it in red, that means you've had TB at some point in time. If there's nothing around it, that means your TB test is cleared and you're good to go. Once you've had TB, the test will always come back positive, and the only thing they can do at this point in time to see if it's still there or still spreading in some way is a chest x-ray. So this is a bacterial infection that most often affects the lungs. This is something really big overseas, especially if you're doing mission trips or things like that. Can remain inactive for many, many years. That's why I said when you get the PPD test, it come back positive. Patients often complain of fever, coughing, fatigue, night sweats, and weight loss. So make sure you wear gloves, eye protection, and this is the ones you have to wear an N95 respirator. Again, we're wearing those a lot more now because of COVID. Acute pulmonary edema is where the heart muscles can't circulate blood properly anymore. So this is going to be your left side of the heart, so your left ventricle not pumping effectively, causing fluid to back up into your lungs. This is what causes acute pulmonary edema, or APE they call it. So fluid builds up within the alveoli and in the lung tissue. This is referred to as pulmonary edema, which usually results in congestive heart failure. So if you have a patient with history, ask them, do you have a history of congestive heart failure or CHF? Well, I'm not sure, but the doctor told me to take a water pill. You look at their pills and it says Lasix. Yep, you have CHF. Most patients have a long-standing history of chronic congestive heart failure. They know they have it, and they just got to make sure they pay good attention to it. So again, this can kill people quickly if fluid builds up to the point where they start getting blood-tinged sputum or pink frothy sputum at the mouth. At that point, these patients here need to be suctioned. They need to be intubated quickly, so paramedic care is going to be needed for those. So as you can see here, the normal versus the fluid buildup, looking at pulmonary edema at the capillary bed. So basically, you're becoming flooded inside. And this starts filling up through the capillaries into the alveoli, going up the bronchioles, into the bronchi, and up the trachea. This can actually happen, and it fills up your lungs full of fluid. It's like someone's internally drowning. One of the most common calls we go on, COPD, chronic obstructive pulmonary disease. So this is a slow process of dilation and disruption of the airways and the alveoli. This is caused by chronic bronchial obstruction. So mucus buildup as well. This also may be a result of lung and airway damage from infection or inhalation of a toxic gas. So again, and also tobacco smoke can create chronic bronchitis. So emphysema and bronchitis are COPD. Those two things make COPD. You can have one or the other, or both. Emphysema is the most common type, though, of COPD. These are the patients you're going to see that barrel chest I was talking about, or what they call increased AP diameter of the chest. What's happened is they've lost the elastic material in the lungs, which then include inflamed airways and also smoking as well. So if you're a smoker, COPD can happen eventually in your older ages. Most patients with COPD have elements of both chronic bronchitis and emphysema, right? So these patients here can become cyanotic very quickly. Their SpO2 readings can be down. I mean, I just had one literally the other day. The SpO2 went down as low as 50%. So these patients need oxygen. Now, if they're perfectly fine and their oxygen is sitting around 90%, they're not showing any signs of distress, ask them, do you retain carbon dioxide? And they'll tell you, yes, I'm a retainer. Well, that's okay then. But again, treat the patient for the symptoms. So this is a normal lung at the alveoli and the bronchioles. As you can see, the alveolus that are there, right? What's happening is, for an inflamed lung, you're going to have inflammation and infection. You can see the mucus I was telling you about in the middle picture there. You start getting mucus buildup. This is your lung inflammation. When you start getting obstructive lungs, you start getting that obstruction. You can see the arrow here, where the mucus is built up to the point where air can no longer get in the alveoli. Because of that, you start getting dilated alveolus, and these things here can start popping, or they can lose their elasticity and causing severe infection. If they lose elasticity, then eventually these are going to start collapsing. So when you apply CPAP, CPAP forces air through here to keep the area open a little bit longer, causing better alveolar gas exchange. And our CPAP levels can go up to as high as 15 for PEEP, and it's providing 100% oxygen at the same time. So patients with pulmonary edema will have wet lung sounds. Okay, so you'll have that rails, that crackly, bubbly sound. Patients with COPD, you'll have dry lung sounds. And this is the biggest thing. This can be easily confused with congestive heart failure. Because a lot of people will say, well, you'll see a lot of articles, COPD versus CHF. How do you tell the difference? So these are very big for us to be able to figure out the difference because they're both treated completely differently. So patients with COPD require oxygen, but the good thing is both COPD and CHF can also get CPAP. The biggest issue comes to the paramedic level on which medications we're going to give, because if you give someone with COPD nitrates, it can potentially kill them. You give someone with CHF, albuterol, we're bronchodilating at this point, and now we're causing more room for fluid buildup. So you got to be careful. You can actually flood patients that way. So the way to tell the difference really is getting a very good set of lung sounds. So quiet in the room, take a listen, get a good in-depth set of lung sounds to find out if you hear wheezing or dry lungs or wet lung sounds. Now let's talk about wet lung sounds for a minute though. If you have a patient with pneumonia, pneumonia is more lobe specific. So you may have clear lung sounds on one side, but then let's say on the left side, you hear fluid buildup or fluid or wet sounds. That potentially could be pneumonia because it's on one side versus both. So it's something else to pick up on during your assessment. Asthma, hay fever, and anaphylaxis are a result of allergic reaction to inhaled, ingested, or injected substance. In some cases, allergens cannot be identified. They just happen. Also, in some other cases, there are no identifiable allergens at all. Asthmatics have mucus obstruction in the bronchioles. So as you can see in the picture on the right-hand side, normal patients, great airway, great passaging. With asthmatics, they just build up a bunch of mucus to the point where it becomes very narrow. These patients need bronchodilators to dilate to make it more look like the normal side again. to allow for better airway exchange. So asthma is acute spasms of smaller airway passages causing them to constrict the bronchioles, making things smaller. So the fix for this is going to be your albuterol, and then looking at, well, for you guys, it'd be more of the albuterol fix. So the MDI inhaler. If asthma is really bad, get the paramedics en route because they have other medications like epinephrine and other steroids they can also assist with these. But you can contact med control and you can assist with the patient's MDI inhaler for that. Asthma affects all ages, but most prevalent in children from ages 5 to 17. What you'll see is the characteristic wheezing. So you're going to listen for inspiratory and expiratory on the lung assessment. You're going to see if there is any wheezing at all noted. If you have a patient that's a really bad asthmatic, when you walk through the door, you may hear audible wheezing. You can hear it from the doorway. You're going to be like, yep, this kid's sick. Let's get him going. Asthma attacks can be caused by an allergic reaction to foods, allergens, or severe emotional distress. Yes, that can happen. Exercise and also respiratory infections. So we need to get a good history and find out what's started this. Now, back to asthma just for one more second here, though. If we've given treatments and treatments are no longer working, this is called status asthmaticus, which means that it's not stopping with treatments, and this patient could end up dying in the back of the ambulance. Status asthmaticus patients that just are not reacting to treatments, these patients here need to get to the ER fast because they're most likely going to get intubated to keep that airway open and provide positive pressure ventilation through a ventilator. So again, asthma can be very dangerous, which is why it needs to be recognized and treated quickly. Hay fever causes cold-like symptoms. Allergens include pollen, dust mites, and pet dander. Anaphylactic reaction can produce severe airway swelling, so total obstruction can be possible. We talked about the tongue swelling as well, and that would be something called, that's what they call angioedema. So treat with epinephrine with these patients here. If they have anaphylaxis, you have an EpiPen. You put it on the right or left lateral thigh, so outside of the thigh. Inject the epinephrine, or we're going to be using, because you're in New Hampshire, we have ready check inject kits. So you're going to be drawing up your own epi using a filter, a needle, a syringe, and a vial. And that's something you can do at the EMT level with the proper training. Another thing also with the airway obstruction, anaphylactic reaction or reaction of some sort, is ACE inhibitors. Just kind of throw that out there. So someone could be on something like lisinopril. Anything that ends in PRIL is an ACE inhibitor for medication. And one of the things that can happen, and it's actually fairly common, patients that are on ACE inhibitors for maybe 3, 4, or 5 years can all of a sudden develop a reaction to it. And the major reaction to that is angioedema, to the point where their tongue swells up so they can't breathe anymore. It just happens. So if you have a patient for unknown reason for tongue swelling, ask them if they're on any ACE inhibitor. Ask them if they're on lisinopril. They may say yes. You may, oh, well, that could potentially be the cause of what's going on here. Kind of interesting how that works. Spontaneous pneumothoraxes, or a pneumothorax is accumulation of air in the pleural space. This causes the lung to collapse. Most often caused by trauma, and if you have a traumatic issue, that's what they call tension pneumothorax versus spontaneous pneumos. This may be caused by medical conditions as well. A lot of these patients that have spontaneous pneumos are going to be white males that are very tall and skinny. I'm talking like 6'2", 6'4", skinny white males. These patients can develop spontaneous pneumos very easily. So what's happening, as you can see, remember your lungs run on a negative pressure system, not positive pressure, negative pressure. With this, if you guys look at this is more of a tension pneumothorax. There's a wound site right here. By doing that, the air deflates the lung because now there's pressure coming in, putting positive pressure on, causing the lung to collapse. So your pleural space, which is all through here, all that purple spot there, okay, becomes very open because now you have air coming in, pushing that lung inside, which then causes the collapsed lung. And then by doing so, this patient can no longer breathe effectively. One of the late signs of this, obviously, one of the early signs is going to be decreased oxygen, respiratory rate changes, tachycardia, and absent lung sounds on the affected side. A late sign is going to be what they call tracheal deviation. So tracheal deviation means that your trachea will deviate to the side that has the working lung. You'll actually see it'll move inside underneath the skin. You'll see it actually deviate to one side. That's a very late sign of pneumothorax. So you want to make sure you catch this prior to that even happening. So this occurs when the lung with lung infection or in weak lungs, where the patient becomes very dyspneic and breath sounds may be absent on the affected side. So take a good listen to the lungs. A pleural effusion is a collection of fluid outside of the lung itself. Compresses the lung and causes dyspnea. So if you go back a slide here, for a pleural effusion, there'll be fluid buildup all through here, putting pressure on the lung, therefore causing dyspnea. This can stem from irritation, infection, congestive heart failure, or cancer. These patients that have pleural effusions, and I've taken a ton of these patients from one hospital to a bigger hospital, interfacility transport. The best position is upright position, which definitely eases the pain. Because this also becomes very painful because they can't breathe, and it's also an infection and swelling in that pleural space. All right, any questions so far? You guys doing good?
Good here.
All right,
Also,
again, chat box is open if you have any questions. So obstruction of the airway, very common. Patient with dyspnea may have a mechanical obstruction. So we treat this quickly. Remember, if a patient is alert oriented, giving you the universal sign for choking, we're going to do abdominal thrusts. If they're pregnant or very obese, we're going to wrap our arms around their chest. We'll do chest thrusts from the back until they go unconscious. Once the patient goes unconscious, we start doing chest compressions. The only difference is when we hit our 30 to 2 mark, we're doing our 2 breaths. We're going to look inside the airway and see if we can see the obstruction. We're going to pull it out. Now, if they go unconscious, something else we can also utilize is suction. So if you see something we can suction out, we're going to suction that out as well. If the patient was eating just before dyspnea, always consider a foreign body obstruction for that. If the area obstruction is something with a histamine release or a distributive type shock like anaphylaxis, then we're going to have to treat that with epinephrine. That's the only thing that's really going to help these patients. Then obviously having a paramedic come on board to give Benadryl, which is a histamine blocker, which is we need to stop the histamine being released in the system. So as you can see here, for the obstruction, we have food occluding the airway. So you guys can see that by the air passage. And then the other one would be the tongue. So one of the most common airway obstructions that we're going to run into is the tongue falling back in the airway. So for some of us, for some people that at home sleep and they snore, that's because your tongue's falling back in your airway, causing airway occlusion. That's why people sleep with CPAP at home, because it pushes that air through. So it decreases the snoring and increases your oxygen levels. So if we have a tongue occlusion, one of the best things we can utilize if they're unresponsive, if there is no gag reflex, we can put an oral pharyngeal airway in, and that displaces the tongue so the tongue doesn't fall back in the airway. Now, if they have a gag reflex, we put in a nasal pharyngeal airway. Remember, bevel towards the septum. We measure it from the corner of the ear to the corner of the nose, and we put a bevel towards septum, and we insert the airway. That will allow, in hopes, when it comes through the nasal cavity into the nasopharynx, into the pharynx, coming down through, it bypasses the tongue, ends up down here, so when we ventilate, it still forces air past that obstruction. That's the plan behind it. A pulmonary embolus, or embolism, is a blood clot that circulates through the venous system, going into the pulmonary arteries, the pulmonary, and basically cutting off partially or completely circulation to the lungs and to the heart. This will significantly decrease blood flow, and if large enough, can cause sudden death. So here's the thing about pulmonary embolus. A lot of times they start with DVTs. So a DVT is a deep vein thrombosis. Most of the time they are found in the calf. You may have, so if you have a patient you suspect pulmonary embolus, some questions you need to ask. One, have you done any long distance travel by plane or by car? Because sitting down for long periods of time without movement can cause DVTs in the calves. All right. Number two, we want to ask them, have you had any chest pain? Right. So patients with pulmonary emboluses, if it's really bad, can have intermittent chest pain and also multiple syncopal episodes. They will appear to be very anxious, and that's not because they're having an anxiety attack. It's because they can't breathe. Right. So they'll be anxious. They'll have syncopal episodes. They'll have sharp chest pain. These patients here are very critical. If the clot is big enough, they can put them into cardiac arrest. The only way to fix that problem is to go in there and remove the clot. We can't do that. It has to be done in surgery. So again, you need to pay attention to that. Another thing you notice on a cardiac arrest patient is look at the nipple line across. From the nipple line up, you'll see it'll be very dark color, very cyanotic. But from the nipple lines down, you'll have like a good circulation patient. Obviously they're in arrest, but you'll notice a line, I call it the line of demarcation, like we find in fire investigation. We see that line across, and we'll see that differentiation. A lot of times that can be a PE. So something to pick up on if you're working in cardiac arrest. Signs and symptoms we just discussed: dyspnea, tachycardia, tachypnea, so rapid respirations, rapid pulse, varying degrees of hypoxia. You'll see cyanosis, acute chest pain, and hemoptysis. So they could also be vomiting blood. Right, hyperventilation, which is overbreathing to the point of arterial carbon dioxide falls below normal. So this may be an indicator of a life-threatening illness if there's hyperventilation. And the body may be trying to compensate for acidosis. And so a buildup of excess acid in the blood or body tissues. So if we have a patient who's very acidotic, we're going to see them start breathing rapidly. Patients that overdose, you might see increased acidosis as well. So again, they may have rapid respirations. So this is something to think about when you see this, or patients that are hyperventilating on purpose to hold their breath underwater for long periods of time, or panic attacks can also cause hyperventilation. So we got to kind of keep an eye on that and control this. This can be controlled, the patient's hyperventilation. Can also result in alkalosis as well, which is a buildup of excess base in the body fluids. I'm not going to cover acid-base balance with you guys, talking about pHs and bicarbs and all that stuff. Just understand that you can also have alkalosis build up with that. But this can cause symptoms of panic attacks, so anxiety, dizziness, numbness, tingling, and painful spasms in the hands and feet. Those painful spasms are called carpal pedal spasms. That's because you've hyperventilated so much that your oxygen is not getting down to the extremities in your feet and your hands, causing them to tingle and kind of curl up. So you kind of notice that they'll curl their fingers in and look like all distorted. That's because they're having spasms in their hands and feet because of the hypoxia and the low oxygen levels. So we have to control their breathing. BVM, control them. That's still not working and they're very anxious. Call for ALS. We have benzodiazepines that knock patients down to help them be able to fix the respiratory drive. Environmental and industrial exposures. We can think about pesticides, cleaning solutions, chemicals, chlorine, other gases that can be released. So back to pesticides. What is the acronym that we utilize to tell if a patient is on pesticides or got exposed to? You guys remember? There's 2 of them you can utilize.
I don't remember.
Talked about it in toxicology. Anybody? So the acronym we're going to use is either dumbbells or sludgeum. Does that ring a bell now? All right, got a lot of yeses coming over. Perfect. So go back to the toxicology lecture and review the sludgeum and dumbbells. So that's how you're going to tell if the patient's on pesticides or organophosphates. Carbon monoxide obviously is odorless, highly poisonous, and produced by a fuel-burning appliance and smoke. Again, if you have patients that are unresponsive in the home, don't put yourself at risk going to save somebody. New Hampshire requires carbon monoxide meters, or CO meters, on every first in bag. We have them on all of our trucks. It's a required piece of equipment to be on your ambulance. We bought the handheld ones to go on your bags. So if you walk into a home, they start activating, you get out. So don't put yourself at risk. Call for trained professionals that can wear SCBAs to get your patients out. If you are that trained professional, put one on, pull the patient out, and start giving them high flow oxygen. Unless they're unresponsive, then we got to use BVM and start ventilating. So with this here, looking at respiratory conditions, we're going to do our scene size up, scene safety BSI. Remember that. Use standard precautions and consider possibly of an infectious disease or a toxic substance. Nowadays with COVID, and I bring that up a lot, if you go to a respiratory call, wear an N95 regardless, because that is going to be your best savior for patients with COVID. Mechanism of injury or nature of illness. If in question, ask why 911 was activated. Why did you call 911 today? Question the patient, family, and other bystanders to determine the nature of illness. What is going on? Why did you call 911? Why are we here? On your primary assessment, identify immediate life threats. Patients that are very tachypnic is immediate life threat. If they're breathing 50 times a minute, we have to control that. If they're cyanotic, that's an immediate life threat. Give them oxygen. Okay? Form a general impression. That's when you look at the patient and say, are they sick or not sick? Note the age and position of the patient. Are they nasal flaring? Are they tripoding? Is there accessory muscle use? We're going to look at all those things for respiratory assessment. Use the AVPU scale. Alert to verbal, painful, and unresponsive. And ask a patient about the chief complaint. So describe your difficulty breathing. Well, I had difficulty breathing all the time, they'll tell you. Okay, why did you call 911 today? What is different today, right now, than your normal breathing difficulty? Well, it's gotten a lot worse over the last 24 hours. All right, thank you. Now let's move forward from there. Assess airway and breathing. Make sure the airway is patent and adequate. If it's not patent, make it patent. Suction. If it's not adequate, make it adequate. Provide suction if needed. Assess rate, rhythm, and quality. Okay, we're looking at how fast or slow it's going. We're looking at the number itself and how many times per minute. Is it labored? Is it shallow? Also ask the following questions. Is air going in? Does each chest rise and fall? Does the chest rise and fall with each breath? Place your hands on their chest and feel. Good rise and fall. Is the rate adequate for the victim's age? Looking at the age group, are they breathing within the ranges? When we assess lung sounds, like I showed you guys over there, using a Z pattern, go back and forth. Don't assess just one side then the other. Go back and forth. Check breath sounds on the right and left sides of the chest, and abnormal sounds include wheezing, rales, rhonchi, and stridor. Wheezing is wheezing. We all have heard of wheezing before. Stridor is that steel barking type cough. You're going to hear stridor on the upper airway, so there's nothing wrong with taking your stethoscope and putting it on their trachea and listening. Rales is going to be your fluid, your bubbling, and rhonchi is going to be more of the mucus type sound, the mucusy type sound that you'll hear. With circulation, assess for shock and breathing. Assess capillary refill in infants and children. So remember, push on the skin, and you want to make sure it comes back in how many seconds?
2.
2 seconds. Correct. That is correct. So 2-second return. Assess perfusion by evaluating skin color, temperature, and condition. So is it warm? Is it cool? Is it feel hot? Is it tenting? Is it not tenting? Is the color pale? Is it diaphoretic and sweaty? Is it pink, warm, and dry? What's going on with the patient? Is it cyanotic? Is it jaundice? Is it yellow? Then reassess any life threats. Make a transport decision. At this point in time, within 5 minutes of your assessment, we need to figure out, are we going or are we staying? If the condition is unstable and there's potential possible for life threat, address the life threats first, proceed with rapid transport. If there's no life threat possible at this point in time, then we make our decision to start transporting or moving towards the ambulance, and also make a decision whether or not you need ALS or not to come meet up with you. Investigate the chief complaint. So objectives, subjectives, observations. Ask the patient questions. Report any pertinent negatives. Do you have any shortness of breath, chest pain, dizziness, nausea, vomiting, diarrhea, headache, blurry vision? All these different things you can be asking the patient and see if they give you a negative response. No, I don't have any chest pain. Perfect. Document it. Find out what the patient has done for the breathing problem. What have you done so far? Have you increased your oxygen on your home concentrator? Have you given yourself nitro? Have you given yourself albuterol? Do you take a nebulizer? Do you use an MDI inhaler? Then get your sample history. So sample, signs and symptoms, allergies, medications, pertinent past medical history, last oral intake, and events leading to the illness or injury. We're going to get our OPQRST assessment, which is onset, provocation, quality, radiation, severity, time. And then the PACE assessment, which is progression, associated chest pain, sputum, talking tiredness, and exercise tolerance. Then we're going to do a more in-depth assessment of the body symptoms. If it's respiratory, listen to lung sounds. Look for equal rise and fall. If it's cardiovascular, get a 12 lead. Even on the respiratory, do a 12 lead anyways. Look at your skin, color, temperature, condition. Get blood pressures. Check them in both arms if you have to. And you may have to do a neurologic assessment, and that's going to be your Cincinnati Stroke Scale or your FAST ED scale. Cincinnati Stroke Scale measures 3 different things. One is what they call pronator drift, when both arms go out in front of you, palms up, to see if an arm falls. We're going to check for slurred speech. You can't teach an old dog new tricks. You can ask for that and have them take a big smile and look for facial droop. That's going to be your 3 things that would indicate stroke. And proceed only after addressing any life threats. Look for signs of COPD. Patients older than 50 years of age. Do they have a history of lung problems? Are you active or former cigarette smoker? If they are, how many packs per day do you smoke? That's a good number to get. How many PPDs, packs per day? Is there any tightness in your chest? Do you have any constant fatigue? The barrel-like appearance or the increased API diameter of the chest? And you'll know when you see it. Any use of accessory muscles or any abnormal breath sounds? And then do your reassessment. So repeat your primary assessment and look for any changes in conditions. And then any interventions you may have done. If you gave oxygen, did it make it better or worse? Do you need to provide positive pressure ventilations because the high flow oxygen is not working anymore? Airway management techniques. So do we need, if they're unresponsive, do we need to put an OPA or NPA in? Does it need to be a head tilt chin lift? Positioning in high Fowler positions or positions of choice. What makes the patient feel comfortable? Most of the time with patients with respiratory conditions, they're going to want to sit up almost all the way on the stretcher. And it sits with respiratory medications, so if the patient has a med and they can't do it on their own, call med control, get orders, and see if they can give you orders to administer an MDI inhaler. So for emergency medical care, obviously administer supplemental oxygen. Some patients may need continuous positive airway pressure or CPAP or utilizing a BVM. So in our practical scenarios, I will show you guys how to apply CPAP as well. Patients may also have a meter dose inhaler, MDI, or a small volume nebulizer. So consult medical control and make sure medication is indicated. So if it's needed, med control, and we'll go over all that more in practical sessions with MDIs. Contraindications, which means things not to do. Patient unreliable or coordinate inhalation. If they can't figure it out, it's not going to work for them. Inhaler not prescribed to the patient. Don't take one out of your back pocket and say, this is mine, but you can use it. Or take a family member's. It has to be prescribed to them. Not permissible by local protocol. Our protocols allow us to do that with med control. Maximum prescribed dose already reached. If the medication's expired, please don't give it to them, or any other contraindications specific to that medicine you're giving. With most medications are used to relax the muscles, so that's our bronchodilation, muscle relaxant that surrounds the air passages in the lungs. Some common side effects of inhalers would be increased pulse rate, nervousness, and muscle tremors. Remember how I mentioned it's a sympathomimetic medication? That's why. We're starting to get that increased pulse rate. Treatment of specific conditions, obviously upper and lower airway infection. We want to make sure we administer humidified oxygen if available. Do not attempt to suction the airway or place anything in the airway at all. If it's upper, and if it's an infection, if you start placing stuff inside, what can happen is you can actually make that swelling worse. So transport promptly and position comfortably. Whatever makes them feel comfortable in the ambulance. Acute pulmonary edema, these patients here require CPAP, 100% oxygen, suction if needed, position comfortably. If they have pulmonary edema, they're going to want to sit up, get them to the hospital. For COPD, again, assist with prescribed inhalers and watch for side effects from overuse. A lot of times patients that have COPD are going to want to continuously use nebulizers. And they eventually can reach to the point where they've taken so many that their heart rate's like the 130s, and it's just not going to be good for them. Transport and position comfortably. Asthmatics, be prepared to suction. So assist asthmatics with prescribed inhaler, provide aggressive airway management, oxygen, and prompt transport. A prolonged asthma attack that is unrelieved may progress into an emergency known as status asthmaticus, which we already discussed. Hay fever, unlikely to need emergency treatment. Again, if you want to go to the hospital, we'll still take them. Anaphylaxis, though, remove the offending agent. So if there is a stinger still in the skin, we got to take it out. Right? So take whatever they're allergic to, remove it from the body, if you're allowed to do so legally. Maintain the airway. Transport rapidly and give epinephrine. That's going to be your auto injector on your right or left lateral thigh. A spontaneous pneumothorax. We're going to provide supplemental oxygen. Monitor carefully for lung sounds, obviously, heart rates, and things like that. So just monitor your patient. Pleural effusion. Fluid removal must be done in the hospital. So they stick needles in and start pulling fluids out. These patients, give them oxygen, get them to the hospital. There's nothing even a paramedic's going to do for these patients. If they have an obstructed airway, partial obstruction, provide oxygen and transport. If it's a complete obstruction, transport rapidly If it's a foreign body airway obstruction, follow AHA guidelines and remove the foreign body airway obstruction that's there if you can. A pulmonary embolus. Supplemental O2 is mandatory. These patients need oxygen. Position comfortably. If there is hemoptysis is present, clear the airway immediately, so blood in the airway, or vomiting blood, suction, and get them to the hospital. Hyperventilation. Complete a primary assessment and gather history. Do not have the patient breathe into a paper bag. That's old school method. It doesn't work. So let's not have them do that. Reassure the patient and provide supplemental O2. Get them to the hospital. And then provide what they call PFA, which is psychological first aid. Get them to calm down if they're having an anxiety attack. If they have an environmental industrial exposure, make sure that patients are decontaminated prior to transporting. Oxygen, adjuncts, and suction is needed. For foreign body aspiration, clear the airway, provide O2. Tracheostomy dysfunction, position comfortably, suction to clear the obstruction, and provide O2. Patients that have trachs placed can develop mucus plugs very quickly, and they know when it happens. A lot of times they do their own suctioning, but you may have to suction a trach out to assist with their breathing that way. Asthma, again, MDIs, and provide blow-by oxygen as needed. And cystic fibrosis was a genetic disorder that affects the lungs and digestive system. So suction and oxygen is needed. These patients here have a lot of mucus built up in their lungs, and they may ask you to do something called percussion therapy. That's basically cupping your hands and hitting their back. What that does is it breaks up the mucus inside to help them breathe better. All right, so let's do some review. So the process in which oxygen and carbon dioxide are exchanged in the lungs is called what? Respiration, ventilation, metabolism, or inhalation?
A.
Perfect. Well, A it is. Number 2, which of the following respiratory diseases causes obstruction of the lower airway?
C.
C.
B.
Yeah, B it is. Perfect. Which of the following diseases is potentially drug resistant and is thought to be transmitted by coughing?
A.
A.
Tuberculosis. Very good. All the following are causes of acute dyspnea except
B.
I see some D's on the chat. The answer is B, emphysema, which is a form of COPD. It's a chronic respiratory disease, therefore it presents with progressively worsening dyspnea. Asthma, pulmonary embolus, and pneumothorax are all acute conditions. Therefore, it's typically present with acute onset of dyspnea. So a lot of times patients with COPD, they'll start seeing the dyspnea get worse over time to the point where they say, we need to call 911, we can't breathe anymore. A bronchospasm is most often associated with and bronchospasms are when your bronchioles start closing.
6.
That's interesting. They put 5, 6, 7, and 8. The answer would be asthma. Remember that asthma is bronchospasms, which is why we get an MDI to cause that bronchodilation to help open up that mucus airway. That's why we do MDI inhalers or albuterol. Number 6, a sudden onset of difficulty breathing, sharp chest pain, and cyanosis that persists despite supplemental oxygen is most consistent with, remember I mentioned anxiety, sharp chest pain, cyanosis, even giving oxygen, it's not helping.
This chapter's a hard one.
Yep. I see some B's and some D's coming up in the chat. All right, moving here. C, pulmonary embolus. Remember I mentioned before about the sharp pleuritic chest pain? So that's the sharp pains in the chest. So nothing would be cardiac related, but it would be the clot in the pulmonary system. Albuterol, which is a beta-2 agonist, is the generic name for, I don't think I covered that one with you guys.
Isn't it D?
Yep, the answer is D. Ventolin's the other name for it. Or Preventil. An acute bacterial infection that results in swelling of the flap that covers the larynx during swallowing. Remember I mentioned that before, that flap. This bacterial infection will also cause significant drooling, along with fever. Epiglottitis, good job. A 70-year-old man recently had a heart attack and now complains of severe difficulty breathing, especially while lying down flat. He is coughing up pink frothy secretions, is most likely experiencing what? Remember how the blood flows through the heart, right?
B?
Yeah, I see some B's on the chat. The answer is B. Remember that the right atria and the right ventricle receives fluid from the core of the body, or the extremities of the body, coming back in. It goes through the right atria to right ventricle to the pulmonary system, okay, to the lungs, to the left atrium to the left ventricle. So the left side of the heart is failing if it's causing pulmonary edema. Which of the following patients is breathing adequately? A, B, C, or D?
B?
B.
Yep, the answer is B. All right. So let's take 10 minutes, 7:36. Let's come back at 7:45 while I get this stuff situated here. And we'll continue on.
Okay.
All right, is everybody back?
I am.
See a couple of yeses. All right, perfect. Continue on. So we're going to do a lecture on immunologic emergencies, so chapter 20. So same thing as before, applies fundamental knowledge to provide basic emergency care and transportation based on assessment findings for the acutely ill patient. And with that, recognition and management of shock and difficulty breathing related to anaphylactic reactions. We'll also look at anatomy, physiology, and pathophysiology, assessment and management of hypersensitivity disorders and or emergencies, and anaphylactic reactions as well. With that. So EMTs often respond to calls involving allergic reactions. We do. That's one of the things we actually do a lot of. Doesn't have to be anaphylactic, but some type of reaction to something, whether it be a medication, a bee sting, to just a scratch where they had a reaction to something that was in that object they got scratched on. So we do respond to different calls, different variety of calls of types of reactions that are out there. Allergy-related emergencies may involve acute airway obstruction. So we talk about the airway dilation that we get along with angioedema, swollen tongue, to cardiovascular collapse, to the point where they start going into anaphylactic shock. So we start seeing hypotension, syncope, altered mental status, tachycardia, and things like that. And the type of shock we're going to see is more of a distributive shock, which goes throughout the entire system. So you must be able to treat these life-threatening complications. You have to be able to see these, recognize them, and treat them fast. Don't be gun-shy to administer epinephrine. If you think the patient needs it, give it. Okay? It's not one of those things you need to wait around. By that point, it could be too late. Distinguish between the body's usual response to an allergen and an actual allergic reaction. So if the patient has a bee sting and they say it itches and it's a little red, but there's no hives, or what they call urticaria, there's no airway compromise, that's just a normal response to an allergen. That's all it is. Now, if we start seeing it spread down the arm, we see some hives coming up, that's an allergic reaction. If we start seeing it compromise airway and cardiac, that's anaphylaxis. So immunology is a study of the body's immune system. The immune system protects the body from foreign substances and organisms. That's what it's there for. So when a foreign substance invades the body goes on alert. The body initiates a series of responses to inactivate the invader. And one of the things that releases is histamine. So an allergic reaction is an exaggerated immune response to any substance. So we start getting histamine release, leukotrienes release as well. It also releases chemicals to combat the stimulus. And that's what the histamine that I was talking about. This is caused by the body's immune system saying, hey, we're going to stop this from happening. The problem with that, in turn, it's also causing us to have worsening symptoms as far as potential for hypotension, tachycardia, and we have to stop that histamine release that's happening. So this is not caused directly by an outside stimulus for this. We have to stop this from happening. So epinephrine helps with the airway compromise, also helps with the blood pressure coming up and everything else, but doesn't stop that histamine release, which means epi may have to be given a second or a third time with this, which is why the paramedic needs to be en route to administer Benadryl to stop that histamine from being released there. Some patients may not know what's causing their reactions. So you must recognize the signs and symptoms and maintain a high index of suspicion. So we need to pay attention to what is going on, how it may have been caused, and actually looking at the body from head to toe. Because there potentially could have been a sting somewhere, there could have been a bite somewhere, there could have been a spider bite. They may not even know. Maybe they're outside mowing the lawn, the spider came up and bit their leg, and they had no idea that even happened. Next thing you know, they're having a reaction. So take a look and actually investigate and inspect the body. An allergic reaction may be mild and local or severe and systemic. When you start seeing systemic, that's when you start seeing full body urticaria, but you're also going to see cardiac and respiratory involvement as well, versus the local reaction, which is can be easily fixed. So anaphylaxis is an extreme life-threatening allergic reaction which involves multiple organ systems and can rapidly result in shock and death. So as you can see, histamine gets released. Those are your chemical mediators and specific antibodies get released as well, without getting too in depth. So the outsource comes in. That's the bee coming in, making the sting and or bite that gets into your system. Toxins get released. And there, at that point in time, histamine gets released to try to combat it, but also does more damage to us, which can cause vasodilation in the blood vessels, which then causes hypotension. It can cause urticaria and edema and pruritus to the skin. By also doing that in the vasodilation of the vessels, your heart then has decreased cardiac output and decreased coronary flow because it's so dilated, it can't pump and it can't flow effectively. In turn, your lungs also start getting vasoconstriction in the lungs and also bronchospasms. So these patients might need albuterol, they need corticosteroids, they need histamine blockers like Benadryl, they need epinephrine. So as you can see, that this stuff can be very dangerous if not treated appropriately and quickly. So these are the 3 common signs of anaphylaxis. This is what they call urticaria or hives, right? So small areas, generalized itching and burning that appear as multiple small raised areas on the skin. They call this anaphylaxis because you're having the histamine response in body system. Because remember, your skin is a body system. It's called the integumentary system. However, this may not be warranting epinephrine at this point in time because there's no cardiac or airway compromise, right? This patient might just need some like 25 or 50 milligrams of Benadryl and he might be perfectly fine. There's still more to the assessment. However, this is called angioedema. So again, if they have areas of localized swelling, wheezing, or high-pitched whistling breath sounds, these patients need epinephrine quickly to hopefully reduce or cause vasoconstriction to allow the airways to be open, and also in turn increasing the blood pressure as a what they call a vasopressor, which is epinephrine as well, that increases blood pressure. I've seen a handful of patients that have been this bad. Some of them have been lisinopril issues as well. A couple handfuls. You may also note hypotension due to vasodilation and increased capillary permeability. So we mentioned that as well. So we're leaking fluids in the interstitial spaces, causing edema, and we're also seeing vasodilation, which then causes hypotension. You're also going to see gastrointestinal dysfunctions like nausea, vomiting, and abdominal cramps. These patients are not going to do well with antiemetics like Zofran or Reglan or Compazine or things like that. They're going to do better with fixing their blood pressures and fixing their organ systems by giving epinephrine and stopping that reaction. So as far as some common allergens that are out there, food may take more than 30 minutes to appear, like shellfish or nuts. Those are the 2 most common that we see. Medications, obviously, antibiotics like penicillin can cause this, or non-steroidal anti-inflammatory drugs like NSAIDs. So that'd be more like your ibuprofens and things like that can also cause allergies or allergens. Medications, if medication is injected, the reaction may be immediate and severe. Now we're putting that right into the bloodstream. So reactions to oral medications may take more than 30 minutes to appear, but also it can become severe as well because it's going through your GI tract. This guy here has a severe case of urticaria. He may require epinephrine, depending on vital signs and also if it's up by his airway. Plants like dust, pollens, and other plant materials like ragweed, ryegrass, maple, oak can cause allergens that can cause reactions like poison ivy, things like that as well. Other chemicals like makeup, soap, and hair dye can cause reactions. Latex is a particular concern to healthcare providers. So we don't have latex in the ambulances anymore. Maine went latex free many, many years ago. And they provide nitrile gloves as the alternative use for gloves in ambulances. But a lot of people have latex allergies. Insect bites and stings. Obviously, when an insect bites and injects the bite with its venom, this is called the envenomation. With this, the reaction may be localized, swelling, and itchiness, or systemic, involving the entire body. Localized, we don't need to treat with epinephrine, but if it's systemic, that's an epinephrine type administration for the EpiPens. Now, we carry Epi Ready Check Inject in our ambulances. Not a lot of services carry EpiPens anymore due to the high cost. However, some patients actually have their own EpiPens. So you may get dispatched to a school or anywhere else where they said EpiPen has been administered. But it does not mean that the patient's okay. It means that for now, things are getting better, but that epinephrine can wear off within 5 to 10 minutes. And you may have to give a second dose or a third dose. Insect stings. Approximately 3% of adults and 1% of children are allergic to the venom of bees, wasps, or hornets. So allergic reactions to insect stings cause at least 50 deaths per year in the United States. A lot of times they don't know they're even allergic to them. They get stung and have a major reaction and don't have any epinephrine available to help them. So again, watch for airway compromise. That's the biggest thing. And cardiovascular as well. The stinging organ is of most insects is a small hollow spine protecting from the abdomen. Projecting from the abdomen, sorry. With this, you need to locate the stinger and we need to have it removed. So the best way to remove the stinger is, so you don't break it off inside, is using like a credit card of some sort and kind of scraping to pull it out. Venom can be injected directly into the skin this way, as you can see here. So honeybees cannot withdraw their stinger. They fly away and they die. Wasps and hornets can sting multiple times. So you may have more than one sting to look for. Insects, obviously, like some ants, especially the fire ants, strike repeatedly, as you can see on this guy's foot. And what they do is they inject a particularly irritating toxin at the bite sites. Almost looks like acne on the foot. Those are actually fire ant bites. So signs and symptoms would be sudden pain, as you can see here, swelling, localized heat, urticaria, redness. In light-skinned individuals, you'll see redness there, and also itching and a wheal. So you'll see as you look here, I'll bring my mouse back up, you'll start noticing this section here where it's starting to swell a little bit. A lot of times the bite will be somewhere located in here. And it starts working its way out, and you notice the redness as well behind it. So we want to apply ice sometimes. It does help. So we carry cold packs in the ambulance. That can help with some of the swelling that you see, like we showed on the previous screen. It can be dramatic and frightening to a patient, and localized manifestations are also not too serious. Again, if it's localized, nothing to be concerned about. Once they start having shortness of breath, chest pain, lower hypotension, things like that, altered mental status, obviously those are critical patients. In severe anaphylactic cases, patients may experience bronchospasm or wheezing. Again, these patients might require albuterol, steroids, obviously epinephrine, Benadryl, things like that, histamine blockers. In chest tightness and coughing, dyspnea, so shortness of breath, anxiety, gastrointestinal complaints, and hypotension, so low blood pressure. Patients may also occasionally experience respiratory failure. If untreated, anaphylactic reaction can proceed rapidly to death. So one of the questions to ask your patient as you're assessing them for an NSAID sting, and they say, yeah, I gave myself an EpiPen. Have you ever been intubated for this before? And if they say yes, get them to the hospital quickly. Because if they don't get treated fast enough, they can go into respiratory failure. So that's a good question to ask. Have you ever been intubated for this before? Patient assessment with this is scene size up, make sure the scene is safe. Now, if there's a whole hive of bees and hornets or whatever it may be swarming around the patient, it may not be of best interest to go towards that patient and get stung yourself. So again, protect yourself. The patient's environment or recent activity may indicate the source of the reaction, like a sting or bite, food allergies, or new medication regimen. So if you have a patient who's having a reaction, say, and you have no idea what's going on, have you started any new medications? Have you been given any new oral antibiotics that you have not taken before? Be mindful of other potential causes of respiratory distress. Just because you think it's an allergic reaction does not mean it's a COPD exacerbation. It could be something completely different. So be mindful of other potential causes. Traumatic injuries may also be present as well. So follow standard precautions with a minimum of gloves and eye protection, and consider the need for additional resources, such as advanced life support ALS personnel. Quickly identify and treat any immediate or potentially life threats. Again, if you're giving epinephrine, it's a life threat. Formal general impression, sick or not sick, may present as respiratory or cardiovascular distress in the form of shock. Anaphylactic issues are what they call distributive shock, so it goes throughout the entire body. Patients often appear to be very anxious, so call for ALS backup and look for medical identification tags, like they might say allergy to shellfish or nuts or something like that. Assess airway and breathing. Anaphylaxis can cause rapid swelling of the upper airway. If this happens, we need to make sure we're giving epinephrine. Epinephrine is given in an auto injector and or, like I said, the Ready Check Inject, and the adult dose is 0.3 milligrams. Something you guys may want to write down if you can. 0.3 milligrams. And the pediatric dose for EMTs is 0.15 milligrams. And you may have to give one or the other depending on the patient. So you only have a few minutes to assess the airway and provide life-saving measures because, again, if epi is not given fast enough, this patient can go into cardiac arrest quickly and respiratory failure. Work quickly to determine the severity of the symptom itself. So quickly assess for increased work of breathing, otherwise known as, if it's rapid respiration, it's called tachypnea. Use of accessory muscle use. For pediatrics, you might, or children, you'll see head bobbing, tripod position, nostril flaring or nasal flaring, and abnormal breath sounds. So looking for wheezing, bronchi, rales, things like that. So we want to assist the patient into a high Fowler position to maximize ventilations. So get them in a sitting position inside the ambulance. If signs of shock, place the patient in a supine position. Now, again, lay them down flat to allow the heart not to pump so hard. If they're in shock, we want to make sure we get that blood flow back to the core. Do not hesitate to initiate high flow oxygen in severe situations using a BVM attached to oxygen. Circulation assessment. may be present with hypotension. So you want to palpate for the presence and quality of a radial pulse. So again, not textbook, this is more real world. If a patient has a radial pulse, normally they have a systolic blood pressure of 90. If they don't have a radial pulse, then check for a carotid pulse. If they have a carotid pulse, normally they have a blood pressure right around 60. Okay? Again, this is not test information. This is not textbook. This is real world stuff that you might be able to, just kind of quick assessments to be able to feel, but still get a blood pressure. Do not make the pulse your only assessment. Get a good blood pressure. Palpate for the presence of the pulses. Assess rapidly for pulse rate. The cool, cyanotic, or red, moist skin. Is there delayed capillary refill? If there is, this may indicate hypoperfusion, which is inadequate state of tissue perfusion, otherwise known as shock. So for this, we're going to treat for shock. We're going to lay them down in a supine position, which is flat. We're going to apply oxygen, high flow, non-rebreather. If we need a position, we can put them in recumbent position as well. That's turning them on to the right or left side, or supine, laying on their back, and prevent the loss of body heat. So these patients need to keep warm. Shock is going to cause the patient to get cold. So applying warm blankets. If they become a little hypothermic, applying heat packs to the groin, the side of the, underneath the armpit, side of the chest and neck, that can keep the patient warm. Definitive treatment for anaphylactic shock, though, is epinephrine. It's giving our IM injection. So we need to make a transport decision, so always provide prompt transport for any patient who may be having an allergic reaction. At least get them to the hospital. Take along the patient's meds, because it could be a medication reaction that's happening. If the patient does not exhibit severe symptoms, consider continuing the assessment and err on the side of emergent transport. We're going to do some history taking, so investigate. Investigate the chief complaint. Why did you call? What's been going on? How long has it been going on for? And what's in the history of the present illness? Identify any signs, associated signs and symptoms, like chest pain, shortness of breath, dizziness, nausea, vomiting, diarrhea, headache, blurry vision, things like that, abdominal pain. So look for other associated signs and symptoms that could be leading towards shock or things like that. As you can see, looking at this slide here, additional signs and symptoms of allergic reaction could include all of this as well. So just pay attention to the signs and symptoms that you see in front of you. That can definitely make a huge difference when assessing your patient. All right, obtain a sample history, and if possible, ask for the following questions. Have any interventions already been completed? Have they taken Benadryl? And if they have, how did they take it? Most likely it'll be PO or oral. And then how much did they take? 25 milligrams, 50 milligrams? We need to know this stuff. Another thing you want to find out also is, an EpiPen been given? Did you take an albuterol inhaler? Did you use any puffs of your MDI? Has the patient experienced a severe allergic reaction in the past? If it has happened in the past, what were the treatments that were done then? And then, were you intubated for this? Did you get a tube put down your throat? They don't know what intubation means. Was a tube put down your throat to assist you to breathe? Be alert for any statements regarding ingestion of food that cause allergic reactions as well. So ask about gastrointestinal complaints. Do you have any nausea? Do you have any vomiting? If you are vomiting, do you know any blood in your vomit? When did you last eat something? Remember that last oral intake on your sample history. When did you last eat? And when you did eat, what did you eat? Do a physical examination. This includes a systemic, head-to-toe, or focus assessment. Again, if you think it's an allergic reaction from a sting or some sort, then we need to do a head-to-toe assessment to find out where it may have been. So yes, if you have a male or female, you need to go underneath the shirt. You got to look at their back, their front, their chest, their arms, underneath their arms, armpits, looking down towards their groin area. I don't go down, take their pants off all the way. I kind of pull them back, take a look. If I see redness, I note it. We want to see all the way down their legs, their feet. Look at everything to find out where, if anywhere, there potentially could be an allergen of some sort coming in, causing that allergic reaction. We're going to assess baseline vitals by checking pulse and respiratory rates, blood pressure, pupillary response, or oxygen saturation. Add to this as well, get lung sounds. Check your lungs. Skin signs may be unreliable because, again, if you have urticaria, it's kind of hard to see certain things as well. So just pay attention to what you have in front of you. Monitoring devices. Pulse oximetry can be a useful method to assess the patient's perfusion status. Again, pulse oximetry is only a tool, and tools can fail. So again, make sure that everything works and coincides with your other assessment. Decisions to apply oxygen should be based on airway patency, work of breathing, and abnormal lung sounds. If the patient says they're short of breath, though, give them oxygen. And then repeat everything that you've done. Repeat your primary, repeat the secondary assessment, look at your focus stuff again, go back over, repeat patient's vitals. This is a sick patient every 5 minutes. If it's a non-critical patient, every 15. A deterioration of the patient's condition could also be rapid and fatal. This can happen very quickly over minutes, depending on how bad that histamine is being released and how bad the reaction is. So monitor for the patient's anxiety levels and mental status. Look for signs of shock. And if it's shock, then treat it. Lie them down flat, supine position, put warm blankets on them, and or heat packs and blankets and keep them warm. Other interventions as well is determine the severity of the reaction. Is it spreading? Is it getting worse? Mild reactions require supportive care and monitoring. Anaphylaxis requires epinephrine and ventilatory support. What they're saying is you got to give epi, intramuscular, and we need a ventilatory support. With that, we're going to be utilizing a BVM to help them breathe. We're going to transport to a medical facility, and we're going to recheck our interventions during our transport. So as far as communications and documentation go, our documentation should include signs and symptoms, reasons why you chose to provide the care you did, and the patient's response to the treatment. So you didn't give epinephrine because the protocol said so. Why did you give epinephrine? Why did you give them an MDI inhaler? Things like that. Document why you did it and the response to it, and then your reassessment afterwards. So the patient appears to be having a severe reaction, or allergic reaction, or anaphylactic reaction. Administer basic life support and provide prompt transport. If a stinger is present, we're going to scrape the skin with a sharp edge of a stiff object, such as a credit card. Do not use tweezers or forceps because that can actually make it so it breaks off inside. Once it's breaking off inside, then we can't get back in and remove it. So use a card, kind of scrape over it, and it should pull it right out. Wash the area with soap and or an antiseptic type liquid. Remove any jewelry from the area because if you have jewelry on and you start getting swelling, they actually cut off circulation. So get the jewelry off before swelling actually happens. Position the injection site below the heart. Right? If you have it above the heart, then that poison that gets inside of you can rush to the heart faster as well. So keep it below the heart. and apply ice and cold packs to reduce swelling. Be alert for signs of airway swelling and other signs of anaphylaxis. All right. Place the patient in a supine position and give them oxygen as needed, and monitor the patient's vital signs every 5 minutes if they're critical, every 15 minutes if they're non-critical. And remember, looking for those signs of anaphylaxis. Okay, so respiratory compromise, GI issues, cardiovascular, looking at your vital signs and all that. So epinephrine is a sympathomimetic medication. It mimics a sympathetic fight or flight response, causing the blood vessels to constrict and reverses vasodilation and hypotension, increases cardiac contractility, and relieves bronchospasm, and rapidly reverses the effects of anaphylaxis. Right, so this is it's got alpha effects for vasculature, it's got beta effects for heart rate and lungs as well. And this is also, epinephrine is also served as what they call a vasopressor, which also increases blood pressure. So there's a lot going on between alpha and beta effects in the heart and the system, in the body itself. Epinephrine is prescribed by a physician and comes pre-dosed in an epi auto-injector and EpiPen. So patients are not going to get drawn up epi. They're going to get EpiPens administered or given to them to bring home. Your EMS service may or may not allow you to assist in the patient's administration of epi. You can assist with it. It's standing orders. There's no med control order for this at all. Keep in mind that some states are not using EpiPens anymore. They're going through what they call the Ready Check Inject system. So again, I will show you guys Ready Check Inject, and we're going to be able to inject stuff into oranges and things like that on one of our practical days. So I can show you guys how to actually draw this kind of stuff up. These are EpiPens. Please do not put your thumb at the black end of it thinking that you can just push on anytime you want, because it does deliver, and it's one hell of a needle, pretty thick. So again, it can put it right through your finger, and the last thing you want to do is administer an EpiPen to yourself, unless you absolutely need it. So all kits should contain a prepared auto-injectable syringe of epi. So looking at the screen here, this is your EpiPen. For this to work, we're going to remove the gray cap that comes off. We pull it off. We take our auto-injector. We find the lateral aspect of the thigh, so the outside part of the thigh, right or left. We push down onto the skin, and we hold it there for 10 seconds. You're going to hear it click, and what's going to happen is it's going to inject that medication into the skin, into the muscle. This is what we call an intramuscular IM injection. The auto-injector for an adult delivers 0.3 milligrams, and the infant child ones deliver 0.15 milligrams. I can almost guarantee you're going to see those dosages again at some point in time on an exam. The side effects of epinephrine: chest pain, headache, nausea, vomiting, dizziness, pallor, cardiac arrhythmias, anxiety, increased pulse rate, and high blood pressure. Do not give epinephrine to patients without signs of respiratory compromise or hypotension. Those who do not meet the criteria for diagnosis of anaphylaxis. Like I mentioned before, if there's no hypotension, cardiac, or respiratory compromise, we don't want to give epi. Because look at all this, going back a slide here, look at all the side effects that are there. Again, all good stuff when the patient is about ready to die from anaphylaxis, but again, a patient that doesn't need it, we don't want to potentially give them cardiac arrhythmias. So we are giving them epi, right? And this can be actually very dangerous if given the wrong way. And keep in mind that this is not given intravenous or through an IV or up in the arm. It's given left or right lateral thigh, because that's the most vascular area of your body when it comes to the muscle as it disperses. Once it's been ejected into the skin through the auto-injector and or through your syringe, Take your hand and massage the muscle area. By doing so, it helps disperse that medication through the muscle as well. All right. Any questions on this at all? Did I hit all your points that you guys were looking for?
I think so.
Perfect. Did everybody read the chapter prior to class?
Nope.
Oh,
I'll be honest, I didn't either.
that's okay. So go back and read the chapters again. This will help you with your exams coming forward, and whatnot. So let's review the 10 questions. So the signs and symptoms of an allergic reaction are caused by the release of
A.
Okay.
A,
go a little bit more. There's one more thing in there. It's not
D.
just histamine. Yep. So the answer would be
D.
D. Those are the two chief chemicals that are released by the body, which try to help fight it. The problem is that we need to stop it from doing that because then it goes like haywire. So the negative effects associated with anaphylactic shock are the results of
C.
B.
C.
you see a lot of C's. C it is. Excellent. Number 3, you are called to a local baseball park for a 23-year-old man with difficulty breathing. He states that he ate a package of peanuts approximately 30 minutes ago and denies any allergies or past medical history. Your assessment reveals widespread urticaria, so rash, tachycardia, high heart rate, and a blood pressure of 90/60. You hear him wheezing, and even without a stethoscope. You should be most suspicious of.
C.
C.
Very good.
C.
What is a wheal? WHEAL. I touched on this very briefly.
C.
I see A's on the chat box, B's. So the answer is A. Remember I mentioned about a little bit of swelling, the raised skin? That's also called a wheal. So you may see that on your National Registry exam. If you see a wheal, remember raised skin. You are treating a woman who is stung numerous times by hornets. On assessment, you note that some of her stingers are still embedded in her skin. You should do what?
D.
Perfect. Number 6, a young male is experiencing signs and symptoms of anaphylactic shock after being stung by a scorpion. That's fun. His level of consciousness is diminished. His breathing is severely labored, and you can hear inspiratory stridor. And his face is cyanotic. The patient has prescribed epi auto-injector. What should you do first? This
E.
sounds like a National Registry question.
A.
I'm seeing A's. I'm seeing some B's. Any other thoughts? The answer is C. The patient is not breathing adequately, so noted by his decreased level of consciousness and severe labored breathing, inspiratory stridor, and cyanosis. Therefore, you should first assist with his ventilations of the bag valve mask. He clearly requires epinephrine, but by restoring adequate breathing first, regardless of the situation. So going back to the question, this is where the National Registry will actually try to trick you, because you guys all feel the patient needs epinephrine, right? I've been teaching you guys that all along. The National Registry wants you to do ABCs before medication administration. And because he's got diminished level of consciousness and his breathing is severely labored, we want to provide positive pressure ventilation by a back valve mask first. Usually this is done in conjunction if you have a partner with you. One's doing positive pressure ventilation while the other one is doing the administration of epinephrine. But this is one of those National Registry questions that will get you. So you got to look at two right answers. Which one's more right than the other? Always remember scene safety, BSI, and then obviously, general impression, ABCs. So airway, breathing, circulation has to come first every time. The most reliable indicator of upper airway swelling during a severe allergic reaction is
D.
remember upper airway swelling, not lower.
A.
A it is. Remember, stridor is upper airway. Okay, so think of stridor as with the other respiratory condition you're talking about with croup. It's an upper airway inflammation causing that high-pitched sound. So that's what you're going to see. Versus wheezing, which is narrowed bronchioles. Remember, so that's lower airway that you're going to find. So stridor is considered an upper airway issue. So the most common trigger of anaphylaxis is what?
D.
We'll see in here D.
D.
See D's, C's.
D.
D. So foods. We get a lot of issues with people with peanuts and shellfish. So food account for 30% of deaths, 30% from anaphylaxis, especially in adolescents and young adults. That's when they find out when they're first allergic to them. The adult EpiPen system delivers how many milligrams of epinephrine to an infant and an adult? So the adult one first, infant second.
B.
Yep.
B.
All right. B it is. And the answer number 10 is B. Here's the question anyways. When administering epinephrine by auto-injector, you should hold it in place for 10 seconds. All right. So any questions on what we covered tonight at all? I know that was a lot of information once again, so please take the time to review the presentation once again. Look at your books, your ebooks, read your chapters, and do your practice exams that are on there. And use your test prep, because that's going to be your savior when it comes to your National Registry, because remember, those questions on there are almost identical to the National Registry examination. And then you guys saw tonight, looking at the review questions, you got tricked up on one of them because it was set up like the National Registry. So remember, this coming Sunday, 9 o'clock, we're going to be starting CPR. CPR cards. So we're going to be doing that, and that will last about 3 hours. Once we clear that, we'll be taking an hour lunch. We'll come back. We'll do practical review. We're going to do assessments again. We're going to nail down those skill sheets. That's going to be the key thing. So once you have those memorized, so I'd start reviewing those tonight for your skill sheets for those, airway management, and then start looking at your trauma ones, like your long bone and things like that. So we're going to start doing traction splinting as well this weekend, or sorry, this Sunday. If you have not already submitted to me your availability for ride time, I need those as soon as possible, so I can start getting those scheduled in, because we now have a second EMT class that's coming to Action Ambulance for ride time, but I told them that you're priority first. So I want to get you guys scheduled in before I get the next class scheduled in. So the sooner the better. If you guys hold off by not giving me your schedules, I have to start putting other classes in first, or after you guys. So please make sure you get those to me Sunday. Health forms, I also need to make sure I get those from you guys as well. I'm supposed to have those before we start ride time. So please make sure you get your health forms in. We talked about uniforms, what we need to wear. Tonight I will email you your preceptor packets, so please make sure you print those off and bring those with you to your clinical sites, because the preceptors have to get those completed. If you do not turn them into me, your ride day does not count, which means you have to do it over again. Another thing to mention as well, since one of our students has already done their first day of ride time, you need to take notes on your calls, because you have to write narratives for all your assessments that you do for patient contacts. So please take notes, and I'll go over the narrative stuff with you guys again on Sunday. Any other questions at all before I let you guys go for the night? Everybody good?
Nope. I'm good.
All right. So is there anybody if you're not going to make it Sunday, please let me know, because you guys do need to have a current CPR card in order to pass the class. So please advise me if you can't make it.
If we have a CPR card, do we need to show up at 9 a.m.? Is that right?
So your CPR card has to be good when you take your national registry. So if it has to be AHA.
So like Mike and I did it 2 months ago when we had Fire 1.
So as long as it's an AHA card, right? Is what you have?
I have to check, but I assume so.
Okay. As long as it's BLS AHA and it does not expire by the time you take your national registry, you are fine. You can show up at 1 o'clock.
They are AHA and BLS.
Okay. So again, if you have an AHA card and it is still valid by the end of class, you do not need to show up at 9 o'clock in the morning Sunday, but you do need to be here for 1 o'clock for the rest of the practical. If you do not attend, you're marked absent. So again, 2 absences can actually drop you a letter grade. So keep that kind of stuff in mind, unless you're excused. So if you already have CPR, you do not need to be in attendance for CPR. Then I will see you guys at 1 o'clock. If not, I will see you guys at 9. So whoever doesn't have CPR, let me know. Any other questions at all? Are we good for the night? Again, my phone is always on if you need to get a hold of me, or send me an email and I can help you out. If that's all, you guys have a good night, and I will see you Sunday.